Welcome to this webinar on infectious diseases point of care testing. The webinar was made possible by the European Union funded Horizon 2020 Project Diagoras and includes microbiological diagnostic and clinical experts representing hospital clinicians, large companies, SMEs and general practice. The webinar is also supported by the American Society for Microbiology. For this webinar, I will present slides on key topics related to infectious disease point of care testing, and I may sometimes say ID-POCT, just to shorten the name, but I mean infectious disease point of care testing. And I will ask the panel for comments after each key topic has been presented. At the end of the presentation, then the panel will be able to add some extra topics or extra discussion points if they want to. The webinar is expected to last for approximately 1 hour. So, first of all, I would like to the expert panel to introduce themselves. Unfortunately, Alex isn't here at the moment, so I will begin with Kostas. Could you briefly introduce yourself?
Yes, good afternoon, John. Good afternoon, everybody. My name is Kostas Mittakakis. I am the head of the International Business Development Group at Hahn Schickard, which is a research organization based in Freiburg, dedicated on lab-on-chip and analytical systems. I'm coordinating the European project Diagoras, based on which the webinar is taking place, and I warmly welcome all the participants on board. And thank you very much.
Thank you, Kostas. Melissa?
Well, it's good morning for me. I'm in North Carolina in the United States, but good afternoon to everyone joining. I'm a professor in the Department of Pathology and Laboratory Medicine at the University of North Carolina School of Medicine, and the director of the Clinical Molecular Microbiology for the healthcare system here. I chaired the American Academy of Microbiology Colloquium on Changing Diagnostic Paradigms for Microbiology, which focuses on point of care and near patient testing. I also served on a U.S. Government Accountability Office panel on multiplex molecular point of care technologies.
Okay, thank you, Melissa. Now, Gijs.
Okay, thank you. Good afternoon, everybody. I'm Gijs Elshout, Assistant Professor at the Department of General Practice of the Erasmus University Medical Center in Rotterdam, the Netherlands. I'm still a GP practicing in Vlaardingen, which is nearby, and I'm also doing research mostly on febrile children in primary care, which includes, of course, infectious diseases and antibiotic prescribing.
Okay, thank you, Gijs. My name is John Hayes. I am an associate professor at the Erasmus University Medical Center in Rotterdam. I'm interested in translating research, technological research, and transforming that into the diagnostic microbiology laboratory. Here are the topics for today's webinar. We do not have time to cover all of the relevant and interesting topics associated with infectious disease point of care testing, but I hope that the topics that have been chosen will provide you with new information and new issues for you to consider with respect to the development, implementation, and use of ID-POCT. By 2050, approximately 300 million premature deaths are expected, and up to $100 trillion will be lost to the global economy due to infectious diseases. Infectious diseases are not only associated with high morbidity and mortality, but also by high socio-economic costs, such as absence from work, burden on insurance systems, etc. Clinical symptoms are not usually a characteristic for a particular disease, so that means we really have to have some kind of infectious disease testing in order to identify the pathogenic agent and also possible antibiotic resistances. Yet the detection of pathogenic agents is still a relatively time-consuming process, taking up to several days and generally requiring centralized diagnostic laboratories. So what can an ID-POCT offer to solve these problems? Well, it can offer more rapid and accurate infectious disease detection and targeted antibiotic prescribing practices. For example, determining whether an infection is a bacterial infection, a viral infection, or a fungal infection, and also detecting antibiotic resistance genes. It can be used to reduce emerging and increasing global antibiotic resistance by facilitating targeted antibiotic prescribing, leading to healthcare savings and savings in morbidity and patient mortality. If we consider the use of ID-POCT in the home, then maybe during the flu season, ID-POCTs could be used for self-testing. There may be fewer family doctor visits because people can test themselves and see whether they're actually infected or not. And there are also maybe reassurance for what I've named here as the worried well. Maybe people who think, well, I have a cold, I have flu, I have to go and visit my family doctor. Well, if they have a test at home, they may be able to quickly determine that they don't have influenza, and then they don't have to go to the family doctor. And I think that the implementation of ID-POCT could lead to a shift in costs from insurers and national healthcare systems, or state systems, to private citizens, and lead to cheaper monitoring and reduced financial burden on these healthcare systems. I'm not actually sure whether that will happen, but it's a possibility if people are self-testing, for example, at home. Well, it may be important to define what a point-of-care test is. For example, for reimbursement of costs within a particular healthcare setting, or for defining if the insurance company, for example, will actually reimburse a point-of-care test. Now, if we look at large organizations such as the College of American Pathologists, they state that point-of-care testing is defined as tests designed to be used at or near the site where the patient is located, that do not require permanent dedicated space, and that are performed outside the physical facilities of clinical laboratories. The International Organization for Standardization, they have a standard definition. The point-of-care testing is testing that is performed near or at the site of a patient, with a result leading to a possible change in the care of the patient. In general, these definitions tend to emphasize the idea that point-of-care testing is done near the patient and leads to better informed clinical decisions. But there are no technological demands in these definitions, including, for example, the need for operational independence, for example, for specimen preparation, or independence from large physical infrastructure, such as electricity, refrigeration, or running water. And therefore, there may be an absolute need when we define point-of-care testing for a particular so-called target product profile, or TPP. Now, TPP is a document that describes a product, its characteristics, features, and target market. And this may be important if users and developers of point-of-care testing want to actually claim reimbursement from insurance companies. So, unfortunately, Alex isn't available, so I will ask all of the panel if they have an opinion on how important the definition of point-of-care testing and also maybe a target product profile is in the development, marketing, and reimbursement of point-of-care testing diagnostics, including infectious disease diagnostics. So, Kostas, do you have a particular opinion on this?
Yes, thank you, John. So I certainly think that defining a point of care, definition of point of care through a TPP especially is very important, because developers and the manufacturers need to know what to respond to. So definition is one thing. Detailed description of the requirements is also important in order to set boundary conditions for the manufacturers, and that's why the TPP is extremely necessary.
So that's actually more important than a global definition of what point-of-care testing is. Really, you need to zoom in and say, this is what our apparatus does. You can call it point-of-care if you want, but this has an individual target product profile.
Absolutely, and for example, it can leave the freedom to the technology developers to choose what technology they would use, let's say if it's PCR or protein analysis or so, but it must define the settings, the intended use and the user, and desired minimum or required functional characteristics. That is certainly important.
Okay, thank you. We can come back to this point later if there are any other opinions on this, because I want to move on. So, we talk about point-of-care testing very briefly. Where could point-of-care tests be used? Well, here are a few obvious examples. They can be used in a hospital, next to the bed, at the family doctor's office, or at home. And there are other areas, of course, like if people are on holiday, at a pharmacy, or maybe in a battlefield, on a farm to test for example, infections in animals, environmental monitoring, maybe sewage spills, and also in space. So actually, POCT testing, including infectious disease POC testing, is very versatile. So why isn't, if it's so versatile, why isn't ID-POCT being universally used in healthcare settings? After all, there are already many ID-POCT devices available, and I will show a few of these later. And it appears that the current success or lack of success of ID-POCT in healthcare settings is not so much dependent on technological issues and the availability of these diagnostics, but on the actual implementation issues and the perceived need for ID-POCT in different healthcare settings. Therefore, in the next topic, I want to outline some of the current implementation issues associated with ID-POCT. I'll focus on ID-POCT implementation in hospitals, at the family doctor's practice, and also a little bit at home. And what we can say is that essentially the successful implementation of ID-POCT in all healthcare settings requires a synergistic interaction between diagnostic developers and end users. So let's start with the implementation of ID-POCT in the hospital setting. Now, hospital settings, the infections are often associated with a range of multi-antibiotic resistant pathogens, including, for example, MRSA, VRE, ESBL, MBL, etc. Therefore, a suitable ID-POCT or target product profile needs to be generated for this setting, and developers should be taking note of the definition or the target product profile for this setting. I think that the main advice to hospital authorities and hospital physicians who may be considering implementing ID-POCT is that the successful implementation of ID-POCT, and indeed probably any point of care test, depends on that authority, that hospital, that institute being prepared. And I mean being prepared at what's called the macro level and also at the micro level. So what do I mean by the macro and micro level? Well, the macro level really means looking at the bigger picture, considering in this case the institutional level rather than the individual department or user, looking at how this will affect the whole institution. That is the implementation of point of care testing and infectious disease point of care testing. This is a little bit a busy slide, but I just want to show a few main details. This is a diagram and article published in 2016, recommending a strategy for implementing ID-POCT at the macro level and within hospital settings. In this case, the diagram is obtained from our own experience of developing protocols for the implementation of POCT within the Erasmus University Medical Center in Rotterdam, the Netherlands. So essentially, we recommend to begin by establishing an internal ID-POCT working group so that we gather together infectious disease specialists, but also other specialists from other departments to discuss about point of care testing and ID-POCT. What we then did was we created and circulated a questionnaire to try and test the knowledge of the end users, the doctors and the nurses within the institution to find out what they were lacking, what they needed, what information over point of care testing. We also try to develop proactively contacts with manufacturers and developers in this case also. The idea is that if institutes, healthcare institutes can feed back data to developers, then that will help target developers, target their technologies and their development processes to what is actually needed within institutional settings and within the, for this example, within hospital settings. And then, of course, the board, as it were, the ID-POCT working group or POCT working group, has to generate particular selection and implementation criteria dependent on, for example, the size and composition of the medical personnel employed, the ratio of the different doctors, nurses, diagnosticians, how ID-POCT will interact with current laboratory management information systems, patient safety and data security, etc. And also it's very important, and I will talk a little bit later, about ID-POCT management and quality control. It's very important to have quality control schemes and quality assurance schemes available within your institution to make sure that the results you're getting from your POCT device is standard through the many months of use of that device. So if looking at the macro level means looking at the bigger picture, looking at the micro level means looking at the finer details. In this case, looking at implementation issues within particular hospital departments. So here are a few examples of micro level considerations for the implementation of ID-POCT. Who will manage the departmental testing, whether to test or not? Are there safety concerns? Are there more complicated sampling and reporting procedures? Where will testing take place? Is there adequate room? Where will supplies be stored? Will the end users need access to new documentation and records? They will need to be trained, of course. Who will the end operators be? Who will be authorized to use those tests? Are the end operators willing to do the task? They may claim that they're so busy they don't want to do the task. And who interprets the results? So these are just a few of the small micro level considerations that could influence the implementation of ID-POCT and POCT within healthcare and particularly hospital institutions. Having described both macro and micro level considerations, I want to now ask what may appear to be a strange question. There have been many advances in laboratory automation fueled by the general requirement for a 24/7 diagnostic lab. There's a laboratory that is able to do and perform diagnostic testing within the hospital setting 24 hours, 7 days a week. So my question is to the panel, do they think that a combination of laboratory automation, a 24/7 laboratory and rapid specimen delivery actually removes the need for ID-POCT in the hospital setting? So considering the hospital setting, maybe if we just speed up how quickly specimens arrive and we automate for the 24/7 laboratory, maybe we don't need point of care testing in the hospital setting. Does any of the panel have an opinion on this?
Yes, John, this is Melissa. I think that both can coexist, and I do not think that these advances in the main laboratory get rid of the advantages of point of care testing, true point of care testing where the patient is. No matter how rapid that specimen delivery is, it's never going to be as fast as doing a test right next to the patient. We have tests now that are molecular tests at the point of care that are 10, 15 minutes. And the main laboratory really still can't compete with that. And I don't think we should compete with that. And so I think there is room for both areas to serve patients, but in a different perspective. I absolutely think both can coexist and should coexist.
Okay, it's interesting that you say should coexist. That's another topic, but okay, we don't have time, but that's an interesting opinion. Okay, thank you, Melissa. Let's move on to the next healthcare setting. So we're talking about ID-POCT at the family doctor's setting. And of course, when we think about the family doctor setting, the diseases, the type of diseases and the resistances that we see may be very different from what we see in hospitals. And the type of diseases we're likely to see in the family doctor setting are upper respiratory tract and lower respiratory tract infections, urinary tract infections, and diarrhea. But of course, point of care testing is already widely used in the family doctor's practice. We have the urine dipstick for detection of urinary tract infections with a result in 1 to 2 minutes. It measures metabolites produced by gram-negative bacteria and also measures, to a certain extent, a degree of inflammation by the production of a leukocyte esterase. But there are problems with sampling in the family doctor's practice. Some samples are easy to obtain and provide relevant information on the disease, e.g. nose swabs, throat swab, nose washings. Urine and feces can be easily obtained for developing and testing rapidly for upper respiratory tract infections, urinary tract infections and diarrhea. However, some specimens will be particularly difficult. For example, it's difficult to imagine that doctors will ever want to or be able to obtain middle ear fluid, for example, in cases of otitis media or middle ear infection. And obtaining sputum or obtaining a specimen directly from the lung via, for example, a bronchoalveolar lavage, which is a washing from the lung, that will be almost impossible, I would say, from a family doctor point of view. So these kind of sampling issues have direct impact on the use of ID-POCT in family doctor practice. There are also useful samples, but they may have grey areas, particularly general inflammation or infection biomarkers, such as C-reactive protein, which can be measured via the blood. And there are obviously high levels which point to an infection or inflammation, and low levels which suggest no inflammation or infection. But there's also a wide grey area. So the point is, if we have an ID-POCT test that, for example, can detect viruses and bacteria, what does the family doctor actually have enough knowledge? In fact, is there enough knowledge available to interpret those results? For example, does a family doctor know what a human Boca virus is? Probably not. Maybe they can look it up quickly in an encyclopedia or something. So if you have a test that can detect human Boca virus, maybe you have to also provide some advice to the clinician, to the family doctor, what exactly this virus is and what it is associated with. And then you have problems with mixed infections. So if you have an influenza and a Staph aureus detected at the same time, do you treat the Staph aureus? Probably. But if you have a coronavirus 229E and a Staph aureus in a presumed lower respiratory tract infection, do you treat the bacterium then? How do you interpret mixed infections? Because usually what you say is I guess that the more information you have, you would think it will be easier to make a diagnosis, but actually more information may make it harder to make a diagnosis. And then, for example, if you have a rapid test that detects antibiotic resistances, for the developers, which resistances do you include in your test? Because resistances may vary per country and over time. For example, there is research showing that people go on holidays to certain destinations, they come back carrying, for example, CTXM E. coli's for a short time, maybe 6 months, but that could change the incidence of a particular antibiotic resistance within the community. And we also have problems in the family doctor arena about quantitation. How useful is quantitation? Thinking about healthy carriage versus disease. If we had an ID-POCT test that could quantify viruses or bacteria, would that add any extra information that will be useful in the diagnosis of disease by the family doctor? Probably not, because as I mentioned previously, a healthy carriage, children may carry large numbers of potential pathogens and be asymptomatic, whereas other children may carry smaller numbers and be symptomatic. So I think, guys, Melissa, the panel, do you see any value in ID-POCT diagnostics providing clinicians with advice? We talked about a lot of things about in the a lot of issues relating to the family practice, but I'm really interested in this concept of providing advice, because I think that's a little bit of a minefield. So Gijs, do you have any opinion?
I think ID-POCT has definitely the potential to help me guide treatment. Especially in times of emerging antibiotic resistance, it is most helpful if a test could tell me if the infection is viral or bacterial. but indeed, I think additional advice about healthy carriage of viruses or bacteria and how to interpret the results are crucial to make the difference in this treatment.
Yeah, I think one of the main problems is certainly what we found in the Diagoras project is that, and that's trying to develop an ID-POCT diagnostic for the family doctor, is that there's a lot of information is missing. We need a lot more information. The family doctors need more information, and developers about things like the incidence of pathogens, interactions, healthy carriage. There's a lot of unanswered questions yet.
Yeah, definitely.
Okay, thanks. Okay. We talked about that. I'm just wondering about legal issues if advice is followed. Okay, so we can see that the advice is available, but I think this may be something that's a little bit, I would leave for another time, but another issue could be what happens if the machine provides advice, especially in America, and the patient dies. Now, it may be suspect whether that decision the doctor made based on the ID-POCT is actually a part of the patient dying because maybe antibiotics were withheld. But that's a legal issue. I think that's a little bit of a, as we say, a wasp nest, which...
say something, this is Melissa, just from a US perspective. We start getting into these algorithms on how to make decisions and to use the POCT results as advice. In the US, this is no longer a point of care testing device. It cannot be CLIA waived. So it has to be, really no extra interpretation is required the way the law states now. So I think there are some hurdles to overcome to get to the point where there's clinical context in what some of these results mean, and that we can enrich what these results mean in the family practice setting. But as it states now, at least in the US, once we get to this state, it would not be a point of care test device.
Okay. Thanks, Melissa, for that. We now move on to something a little bit different, and that is the healthcare setting in the home. So I guess healthcare and diseases in the home really mirror the kind of diseases that we see in the community, and therefore in family practice. What I will say is the internet makes it possible to order self-test kits against a range, for example, of STDs here: chlamydia, syphilis, Candida, and HIV. So you can order these test kits online, and this is one of the problems of ordering test kits online. This is from a free Dutch newspaper from 2013, and it says experts worry about the rise of chlamydia self-testing. And their worries seem to be confirmed because if we look at, for example, a point of care test, in this case, the Handy Lab test, and this was a publication by Van Dommelen et al. In 2010, they found that the sensitivity of the Handy Lab was only 12%. So that means there are many false negative results. So let's say you're a young person, you have lots of sexual partners, you think you have chlamydia, you test yourself with a similar test, you have a false negative, so you think, okay, I'm free of the infection, I can carry on with my sexual behavior, unprotected usually, I guess, and that could infect more partners. So there are consequences for false negatives using home testing kits. And of course, chlamydia is perhaps not as important with respect to morbidity and mortality as HIV, but I think it gives a good example of how careful we have to be if we're thinking about moving infectious disease point of care tests from the family doctor or even from the hospital into the home setting. However, here are two examples of another aspect of at-home testing, currently in use and under development, based on smartphone apps with or without additional diagnostic devices. It could potentially save unnecessary visits to family or hospital doctors. On the left is an award-winning app that allows patients to take photos of infected or healing wounds via a smartphone. This information is then sent to a remote physician who can provide advice to the patient without the patient suffering the inconvenience of having to visit a family doctor or a hospital. On the right is CellScope's app for worried parents regarding childhood rashes. A parent can take a photograph of a childhood rash and send the picture to a clinician or physician, a doctor, who will provide advice. And here also by CellScope, a rapid method to quickly check for otitis media, middle ear infection, which is particularly common in babies and infants. A special adapter is added to a smartphone so that a photograph of the eardrum can be taken, and then the photo can be sent to a doctor at a remote location who can study the photograph and offer advice. Parents can also, by the way, contact their own pediatrician if he or she is part of the scheme. So these are the kind of things that are available now in the ID-POCT area. You have kind of what I call the quick and dirty test, the dipsticks, the lateral flow tests, and you have sort of also the apps, which are becoming more and more available. And I'm thinking here particularly about infectious diseases rather than healthy lifestyles. So I would like to ask the panel's opinion. Will we see more of this kind of particularly infectious disease point of care testing diagnostics at home in the future? So has anyone any opinion on that? Kostas?
So this is Kostas, yeah, this is Kostas from Hahn Schickard. I think it may possibly be the case with the intention to decentralize hospitals and clinics. On the other hand, it has to be handled really with care at home, and especially from the perspective of the interpretation of the result, rather than if it's easy or not easy for the patient to do a self-test. Because in a conference I was recently in Geneva Health Forum, some US delegates talked about the risk of untrained persons performing the test from the perspective of interpreting and self-management. For example, what happens if you do an STI, sexually transmitted infection test at home? It's positive, and then you are alone at home. How do you do it? It is not really, it cannot be foreseen how each individual is going to respond to that. I think it needs a bit of care, especially from the liability perspective that we also mentioned earlier.
Yeah. So basically, we're coming, I think, to the next topic, which is about quality, maintaining quality and training standards. And at the home, in the home environment, you really need, if you want rapid diagnostics, they have to really be foolproof. So basically, taking a picture of a burn wound or something is quite, I guess, foolproof. Whereas if you have to pipette some urine 5 times into a into a stick, then there may be a possibility for error. And that brings me on to the next slide and the next topic, which is related to quality, quality management, data management, and connectivity. You may remember from a previous slide that I talked about quality in terms of, for example, sensitivity and specificity. But in this case, I want to look at the steps that ensure that the original quality of the test, once it is implemented, let's say within the family doctor or within hospitals, how is that maintained? Well, that the quality management of infectious disease point of care testing, just as similar to other testing technologies and testing techniques, can be maintained by the use of quality control, which makes sure that the results of what you've done are what you expected, and quality assurance, which makes sure you are doing the right things the right way. Now, it still can be a little bit confusing. I like this kind of definition. The quality control is product orientated and quality assurance is process orientated. So QC looks at the results of the product, the device, the diagnostic, and the QA looks at everything from specimen receipt to labeling to the device, the diagnostic result, to reporting of the result, etc. So basically, quality control with respect to ID-POCT is intended to ensure that the device being tested generates results that are consistent with the results obtained using gold standard. and any difference should lie within a certain defined error range. Now, quality control testing is usually performed using samples. These can be blind samples of known concentrations of analyte. As can be seen in the figure here, ideal quality control protocols may vary depending on the complexity of the POCT device. And POCT developers really should build some kind of automated QC check into their devices. In practice, however, this may be rather difficult to achieve unless, for example, the device is programmed to alert the user that it's now time to perform a quality control test. If we look at quality assurance, I think there are really two choices here. Samples for quality assurance testing can be internal samples that are distributed between multiple sites. So you have a range of healthcare institutions that are sharing samples so they can look at and compare their own processes and check that they're all getting results which meet with gold standard and also meet with the standard set by the other hospitals in their region. Or more usually, external quality assurance, external quality schemes can be implemented using external companies. In this case, I just placed one company here, QCMD, who maybe they send samples, blinded samples to laboratories who are members of the scheme. The laboratories process the samples, provide results, and then by looking at the company's website, they can compare their results with anonymized hospitals and institutes, healthcare institutes within their region. Now, importantly, quality control and quality assurance of point-of-care devices offers some unique challenges, including the fact that doctors and nurses may think because it's a point-of-care test or an ID point-of-care test, it's a new state-of-the-art test, so it's infallible. It can never give a false result. So we have to make sure that doctors and nurses, end users, are aware of the fact that ID-POCT tests, like all diagnostic devices, can occasionally make mistakes. And we also have to train and provide competence factors for the people going to use the test. And training and these the management of competence can be dependent upon the number of end users, the different educational backgrounds, let's say between a doctor and a nurse. The trainings have to be periodic. They also have to be refreshment trainings. We need to have a logbook somewhere of competent end users. And don't forget again that physicians, doctors and nurses, they may have a high workload. And that may affect the competence of the way they use their device. They may say, well, okay, it's my dinner time is, my break time is over 5 minutes. I should incubate this for 10 minutes. I will incubate for 5 minutes and then put it in the machine and go for dinner, and then I have my result. And there are also technical aspects. So there may be within an institute or within a group of family practices, there may be many places to control. There may be multi-target quality control and quality assurance specimens necessary. So more and more we are seeing not ID-POCT devices that detect a single pathogen or even 2 pathogens, but you're seeing devices that can detect 20 pathogens. So that means the complexity of your quality control and quality assurance scheme also increases. And some of these pathogens for quality control and quality assurance can be difficult to obtain, even for commercial companies. Think, for example, recent Ebola or Zika virus outbreaks. The kind of pathogens for quality control and quality assurance can be quite difficult to obtain in order to make sure that the testing on the front line, as it were, in the villages or also in local hospitals are meeting quality standards. At this point, I'm just briefly going to mention something about connectivity or lack of connectivity between POCT devices. This is just one example of point-of-care test device. Point-of-care testing program, software for data management from POCT tests. I'm not advocating this program. This is just an example of, at the moment, let's say, a very good comprehensive system. They can manage point of care data, not just infectious disease point of care data, but point of care data from within lots of departments within within a particular institute. For example, this software allows you to manage your device, manage the operators, training, nurses and doctors, etc. Quality control, competency management is also in there. Compliance management, mobile access, inventory management, and remote monitoring. Eventually, if we can get data management and we can get software available and it's useful to link different point of care test devices within departments within hospitals or family doctors, but also further afield, if we can concentrate on that, then we open up a new field of personalized medicine where different infectious disease point of care test diagnostics, but also other point of care test diagnostics from within the home, within the family doctor, within the hospitals can all talk to each other. And we can build up this kind of personalized medicine approach to healthcare. So we can work towards personalized medicine. So connectivity is very important. I think something that that's maybe lacking at the moment, where developers should be also concentrating on. So again, to all partners, how important do you think that quality control and quality assurance and connectivities are? So Kostas, do you have anything on?
Yeah, so I think you are touching very important aspects here with quality control, quality assurance. I think these issues are as important as the actual performance of the test. And in this Geneva Health Forum I was last week, the delegations focused a lot on the connectivity, what you mentioned in the previous slides, as well as the precision medicine. They emphasized that quality of care is even more important than just have a quick and cheap care. And certainly the quality control from the developer perspective, the quality control and assurance should be taken into account early enough in the development phase and also allow loops for improvement.
Speaking of connectivity and also quality, but more about connectivity, maybe I'm going to go forward, connectivity has a special place in low and middle income countries.
Yeah.
Because in that way, if you're using, let's say you're out in the field, you're out in the desert, or you're in an isolated village, if you can get hold of a rapid test, point of care test, then it could be easy, or it would be easier to be able to connect your result to, let's say, a national database that would help provide advice without actually having to have a clinician there present within the village. And that brings me on to ID-POCT for low and middle income countries, and to ask really, is this a special case? Because these, obviously, because they're low and middle income countries, and maybe a lot of the diagnostics that have been developed and are being developed are aimed more at higher income countries. And the World Health Organization you may be aware of these guidelines, the assured guidelines, which basically mean guidelines based on affordability, sensitivity, specificity, user-friendliness, rapidity and robustness, developing ID-POCT devices that are equipment-free and that can be delivered to the end user. And these guidelines were really set about a way to help focus developers to make and develop devices that would be useful for end users. So these are the assured guidelines or criteria. And this is some examples of what exactly the assured criteria are talking about. So affordable, let's say, of course, that speaks for itself. If you're in a lower middle income country, you may not be able to afford an ID-POCT diagnostic apparatus, preferably, certainly for lower middle income countries. Tests that are user-friendly. We talked about at home as well, home testing, that there are some minimal steps necessary in order to perform a test, and to perform a test with a certain amount of quality. Also, the test should be rapid and robust. Think about hot countries where there's a lack of refrigeration, also for transport and storage, in dusty, humid environments, and how high throughput the diagnostic device is. So if you're aiming a diagnostic device that's going to be used in a small village, then having a high throughput is probably not the type of device that's going to be useful. Also, of course, equipment can be very important. The equipment that's designed in low and middle income countries, easily disposable with connectivity and also power, maybe with a battery or a solar battery. And also think about the consumables, the effect on the environment, and also delivery to the consumer, whether the device is ready to use or you have to have 6 different cartridges and you have to have buffer mixers and everything that also have to be transported along with the device itself. And whether the device is portable, if you can put the device on the back of a bicycle and the healthcare worker can cycle from village to village using the device or not. And there is an institution, FIND, you may be aware of this, the Foundation for Innovative New Diagnostics, who are particularly available and helpful in implementing point-of-care testing and helping give advice to developers of point-of-care testing in low and middle-income countries. And this is the kind of information that FIND can produce for developers or even for users. For instance, here we have fact sheets about trypanosomiasis, developing new diagnostic solutions for leishmanias, etc., including TB. So this is a kind of a website and an institution that's very useful. So I want to ask, for example, we talked about WHO talks about the assured guidelines. We have FIND as well. But are these assured guidelines actually achievable within a single diagnostic? And the other point is, should we be going beyond assured values? Think about, particularly in low and middle income countries, social issues, gender issues. If you have a male doctor or healthcare worker testing a female, is that allowed or not? What about stigmatization? If you have a test in your village and you're HIV positive, will that lead to stigmatization so that patients will not want to be tested? And then there are trust issues. Most probably it's better to include a local tribal or religious leader to explain exactly what the testing is about and to help implement the testing. So that's something that's above the assured values. And also something to do with behavior change. For example, many people, including low and middle income countries, may go to their healthcare worker or a doctor expecting antibiotics. So to all the panel members, is it feasible to presume that an ID-POCT diagnostic can be produced that meets all of the assured criteria? And if not, what are the major barriers? Maybe Melissa, do you have any opinions on this?
I do, and I was going to comment what I learned at the Government Accountability Office program that I worked with on our report was we had a number of members present who were engineers who had the technology but didn't know how to use the technology. So that was the first time I realized the technology is there. And I do think there's technology that can meet the assured criteria, particularly for low middle income countries, and that these should be goals. But as you pointed out, very important to expand beyond the assured criteria with some of the social behavioral aspects of it. But from a manufacturer perspective and an engineering perspective, the technology both on a protein basis and nucleic acid basis exists. We just have to bridge the gap between the engineers and the clinical context.
Okay, interesting. Kostas, do you have any, maybe there's something about you've gained from your knowledge of diagnostics with your malaria, for example, diagnostic?
Yeah, so I think that I certainly believe that assured criteria is a very nice way to wrap up the general context for the requirements. Then the technology developers should then focus on specific target product profiles that we mentioned earlier, which are more detailed. And there are organizations like the WHO, FIND, MSF, who have issued already for some diseases like tuberculosis, Ebola, bacterial, viral biomarkers. And I would also like to mention that sometimes those TPPs are pretty demanding, and the organizations do consultations with developers in order to see what is actually realistic. For example, if there is a requirement for like 20-plex panel, then there cannot be simultaneously a demand for $1 cost. Therefore, there has to be a balance and a prioritization of what is more important for particular settings and users and so on.
Okay, well, thank you both. I now want to, we've gone fairly a little bit of detail about what we know now and what we think are the issues now. I want to really now take a look into really into the future, and I'm not going to take too long because I see that we're running out of time, but I want to look at current and future trends, and I think the field of the technologies involved in ID-POCT and POCT in general are really interesting. And I just wanted to give a few examples of some of the newer technologies that are being developed and have been reported. But first, I think we have to appreciate that traditional culture techniques for bacteria or fungi as well, they've been around for 100 years, and in bacteriology, they're still the gold standard. Although we know, for example, with 16S and genomic sequencing that there are lots of organisms which can't be cultured. So I wouldn't necessarily say with ID-POCT that traditional bacterial culture is dead. Of course, that process may already have begun with the molecular laboratory. We talk about PCR and nucleic acid amplification. And here are a few examples of, for example, Bio-Rad and the Gene Expert kits, which are already available for use in clinical laboratory, diagnostic laboratories. There are also some so-called point-of-care testing devices, but these are more implemented in the food, pharmaceutical and cosmetic industry, and here are just two of those, the BAC system and the Milliflex system. In clinical medicine, again, as I mentioned previously, we already have quite a lot of ID-POCT devices available on the market, but they're not being implemented. So, and they all have what seems like great characteristics. So there's obviously more than just technological issues involved in ID-POCT. Most of the current technologies are based on nucleic acid amplification technologies, such as PCR. There is at least one, I'm talking about a relative tabletop device that is available that uses antibody-antigen interactions as an ID-POCT diagnostic. That's from ArcDIA. And I'm not saying that any of the tests is any better than any of the other. I'm just giving you a few examples of what are available. But the future trend is to try and miniaturize the technologies that are available, whether that be nucleic acid amplification or non-nucleic acid amplification, or even culture-based. And here is a range of factors which are currently being investigated in new technologies as part of that assay miniaturization process, including also faster turnaround, interoperability, etc. So here is going to go quickly through a few examples. You can, if you're interested, you can read the slides at your own pace later. But this is a lateral flow technology, an advance in lateral flow technology. Lateral flow is really kind of a dipstick technology, but this is by Linear Diagnostics apparatus. Which has just been published. And here they use they have multiple targets, and they capture molecules and detect these molecules via polarized light. What's interesting, we have a single step processing, no multiple washing steps involved here. So this is just one of the new lateral flow technologies that has been published. Also, we have imaging. I was talking about culture. This is published in PNAS, and here they're developing a test for urinary tract infections and to look at antibiotic resistance. And what they do is in urinary tract infections with lower concentrations of bacteria, they force the bacteria into channels, and maybe you can see the E. coli here. Then they feed antibiotics through the channels, and they see over a period of time if the bacteria grow in size or not, compared if it depends on if they are resistant to the antibiotic or not. So that's a really neat way that culture is being used as part of a technological advance to rapidly detect, in this case, antibiotic resistance. Here we have some kind of self-powered device produced by Purdue University in America. And this is a device which generates basically its own electricity. So a small charge of electricity by pressing on the electrochemical device, or SPED. And you have a paper-based device and results can be shown by a color change. So this may be important, for example, in removing testing devices from the need for electricity or mains electricity, being able to quickly generate enough current to run a simple diagnostic test. So maybe the future doesn't lie with technologies, maybe with technological change, maybe it lies with biological advances. So for example, with isothermal techniques, you may have heard of LAMP technology, and there's the ELERA platform nicking enzyme amplification reaction, which use isothermal techniques instead of the, let's say, more traditional PCR techniques for heating, cooling, extension, heating, cooling, extension. And these, for example, LAMP, the techniques, these kind of techniques can be particularly useful, for example, in lower middle income countries where you don't need an expensive thermocycler. You can perhaps hold the tube in your hand or have a simple incubator to perform your diagnostic testing. Also, genetic engineering is also a biological, something for the future, biological process. Here we see from Columbia University, they genetically engineered a yeast, Saccharomyces cerevisiae, a baker's yeast, and they added receptors for Candida albicans in that yeast. They also added red genes, genes that produce a red compound called lycopene from tomatoes. And the idea is by adding the baker's yeast to a dipstick, that you can use this device to detect Candida albicans pheromones. So you can detect the presence of Candida albicans, let's say maybe in the blood culture, using just a simple dipstick device based on genetic engineering of what is a non-pathogenic organism that then has within it genes or receptors, proteins from a pathogenic organism. And in this case, because it has genes from the tomato, a positive result is shown by a change from a white to a red color. Also, I think very interesting is synthetic biology. Synthetic biology integrates, here, and I quote, engineering principles to build sensors, control circuits, and actuators within the biological substrate according to clinical specifications. And I give 4 examples here. This is based on a publication by Slomovich in 2015. So the diagram shows how synthetic biology can be adapted to in vitro and point-of-care diagnostics. So in part A, the inhibition of mRNA translation is relieved in the presence of a transactivating tRNA. So I don't have the time here to go specifically explain in detail, but the idea is that translation is inhibited. You see here by this complex, the ribosome can't bind to ribosome binding site until this tRNA interferes and produces a linear gene, and then the ribosome can bind to the gene, and you get a production of proteins. Here is another example. This is what's called a so-called toe-hold switch model. And the ribosomal binding sites are located in a hairpin loop. Here we are again. Oops, sorry, wrong again. In the hairpin loop, that's the RBS here. And we have a trigger RNA. So instead of a tRNA, you have a trigger RNA, which allows linearization of the hairpin loop. So it's a slightly different process than A, but again, it's dependent on the fact that without the presence of a particular RNA, the protein or translation does not occur because ribosomes cannot bind to a ribosome binding site. In C, we have here, in C, here we see phages that have been engineered to generate bioluminescence when they infect a particular bacterium. So you could think of an E. coli or a Staph aureus phage. You put that into your sample, and if you see bioluminescence, then it means that your phages, that the bacteria are present, the phages have infected the bacteria, produce many thousands, 100,000s of copies, including bioluminescent proteins, which you can then detect in the reaction. In D, we see kind of paper-based systems. It can be assembled by freeze drying with coupled transcription translation systems onto paper or porous materials. And the gene becomes activated when rehydrated with the test sample containing target RNAs or small molecules. So I think here what's interesting is that you can use very simple diagnostics, paper-based diagnostics, but you can combine that with rather complicated synthetic biology components. So not all future-based ID-POCT systems may be based on technological engineering principles. They may be based on biological principles. So I know I went through very briefly, quickly, but I'd like to ask the panel if they've seen any kind of technology or they know of technology that they think could be particularly useful in the future, which they think, hey, that technology, that is going to take over infectious disease point-of-care testing in the future. Kostas, you're an engineer, so you may have a...
Yeah, yeah, I definitely agree with your sort of epilogue, which is that the advances in biology are shaping the future. I agree with this. And one particular example which is very important is, in my opinion, is the isothermal amplification, which is rapidly catching on and being integrated in devices and systems. As well also the combination of the ease of use of lateral flow tests with the specificity of nucleic acid amplification would possibly also give a big thrust to this whole context.
Mm-hmm. So Gijs, I guess for a family doctor, having a dipstick, as it were, is probably preferable to investing in a big machine or an expensive machine. And so having dipsticks, maybe you can buy 10 or 20 at a go and use them when there's, for example, there's a flu season. That would be more attractive than maybe investing in a device that's a tabletop device. You think that's something for the future?
Yeah, I think so. I've seen what you told us is a lot of interesting technology, but I think it's really important for the producers of those technology to keep in mind how it is helpful for the clinicians in primary care, also in the hospital, and whether their technology is feasible to perform in those settings. And that includes, of course, pricing and easy to use.
And quality. We mentioned quality as well.
Quality also, yeah, definitely.
Yeah. And Melissa, what do you think about for low and middle income countries? Do you think there's some kind of technology? You mentioned some. Do you think there's going to be more development of ID-POCT in low and middle income countries, and then it's going to be implemented in higher income countries, or is it going to be the other way around?
Yeah, that's a good question. I mean, because it's all about the market. And while there's a great market in low and middle income countries, it often doesn't pay the bills for the clinical trials that have to be done. So if I had to hypothesize, which is just that, it would be that developers are really looking towards developing for developed countries and then making them accessible to lower and middle income countries. Like some companies have done that, right? We pay one price for a Cepheid cartridge. It's very different in other areas of the world from a public health pricing perspective. So I don't think there's one particular technology, but I do think it's very exciting to see very different approaches to how we can get to very simple technology that can be done worldwide.
Yeah, I think it's true. And also what everyone says, technology is very exciting, but again, we should not forget the implementation issues. So I would like to take this opportunity to say thank you, Kostas, Melissa and Gijs. Sorry that Alex was not present, but I think we still have a great conversation and we had a nice webinar. So I would like to thank you all and sign out here, and wish you well with either your ID-POCT development with your